Good morning, everybody. I'd like to introduce our third and final keynote of the conference this morning, and that's Dr. Matthew Fay. I first met Matthew 2 years ago in Manchester, where I saw him present on the use of wearables for ECG monitoring within the community. And Matthew is a GP across the Queensbury Willows medical practice up in West Yorkshire. He's also a co-founder of the Westcliffe Cardiology service. And I can safely say you are going to be in for a very interesting presentation. Matthew last year came down for our one-day symposia, and there was many questions posed to Matthew during and after his presentation. And this morning, I've certainly allowed time for questions and discussion afterwards. So please, let me introduce you to Dr. Matthew Fay.
Thank you, Hannah. Hi, so it's really nice to be back. This has got to be one of my favourite campuses in the country. It's such a lovely place to come to. And that's from a northern lad who doesn't like to travel south too often. Just quickly about my disclosures, I can bump into various drugs, and I do like people to know that I talk to anybody. When I was invited to do this talk, I thought, where can we get some inspiration? So I decided that I would go to a true expert and genius. So we're going to find that we're going to get a few words of wisdom from Albert during the presentation to try and pull things together a little bit. Now, my brief for this presentation was, what is primary care doing in a very rapidly evolving NHS? It was interesting being in the session before, hearing about how certain parts of the NHS seem to be quite sludgy and slow, where actually the delivery end of the NHS is having to change quite quickly. Unfortunately, not all the reasons for that are due to advances in clinical science. Some of it is just due to the necessity of the day, due to finance and personnel. So I wanted to start off with a question about what is primary care, because whenever I talk to consultants, they're very, very clear that I'm in primary care. When I ask them to define that's a little bit harder. What we can definitely say from our political masters is that they feel that primary care is very important. What is harder to say is what is it? Because a lot of people actually confuse primary care, which I would say is care in the community almost, with the idea of the general practitioner. Because actually, when you think about the general practitioner, I am not primary care. I am just part of a team that delivers healthcare and increasingly social advice in an out-of-hospital setting. So, as with everything in this technical age, when we need a definition, I went to Wikipedia to see what they said. And they said we treat acute and chronic illnesses. Now, Bill, one of my patients who brings in his letters from the government that he can't read, hasn't got an illness that is recognised. He's just got the consequence of being an older man in a post-industrial city that didn't learn to read very well. So actually, I don't know if all we do is actually treat illness. I think one thing we don't do very well is educate about health. And again, in the presentation before, I commented on the fact that when you have a consultation with the doctor, you have a limited amount of time. Most practices sit with the RCGP's recommendation that an appointment should be 10 minutes, which is 600 seconds. And 600 seconds is not a long time, particularly when somebody can take several of those seconds just getting from the waiting room to my door. In my appraisal documents and when I seek my patient satisfaction surveys, I'm always scored high on the fact that I greet all my patients at the door, because that's very nice. What they don't realise is I'm dragging them in to try and maximise my 600 seconds. So we have to think about what we can actually achieve in that and how can we go forward. But if we think about general practice, as I say, you have to think about what my team is. And my team is me and my GPs, and across our group we're very into partners as general practitioners, so we don't have quite as many salaried staff and we try to avoid locum doctors as much as possible. So most of the GPs, or over a half of the GPs in the affinity group, are actually partners of the affinity group, which is very helpful. We have our healthcare assistants, who many practices, they just take blood. In our practice, we're upskilling these people to do more and more and more. And as I'll go through the talk, I will show you protocols we are writing to enable the less clinically educated, but not necessarily less able, to actually deliver healthcare in chronic conditions. I have my reception staff. And again, I think this is a term which is slightly denigrating to the idea that these people are like the reception staff at a hotel and will make sure you get to the right room or will just check you in for your appointment. Our reception staff are the first point of contact for nearly all our patients. And we should be using them more to spread messages around health education and possibly the fact that maybe you don't need to see the doctor, you need to see somebody else. So we need to use these people as much as possible. And then we have the part of general practice which is kind of smashed off. And that's where we have our district nurses. I have nurses that work regularly in my community, but I have no determination over what they will do. And the health visitors now belong to public health and the local council. Again, no control. Pharmacists. There's a lot of pharmacists. Any pharmacists in the room? There's a lot of pharmacists out there. And they can't get jobs, but they're clinically trained and very able. And we're actually starting to bring them inside the practice and recruit them directly to our team. Because again, in a protocol-driven healthcare system, they can follow protocols and assist people with medications. So we have to start mixing up the team a little bit. But general practice is not just the general practitioner. And practices that think that is the truth, unfortunately, are not going to last very long. Just briefly on how we're contracted, because many people don't understand this, but I'm contracted under a block contract, which is the general medical or the personal medical service contract, PMS or a GMS contract. And the reason I want to highlight that is because we are not employed by the NHS. We are all GPs, are independent businesses, who are our major contract is the NHS. And the general medical service contract is what we live under. And it's why so much work is tried to push into general practice, because we don't do much of it piecemeal. So if you shove something into general practice, we don't get paid more. It's all in our big block contract. However, there are bits to it. So we have the core services at the bottom, which is anything you can describe. The additional services, now that's where the government tried to keep us all afloat by occasionally giving us a little bung of money to do something else. At the minute, it's providing appointments from 6:30 to 8 o'clock outside our contract. So there's always ways we can do that. The QOF, which I'm sure you're all aware of, is the Quality and Outcome Framework. It's how we manage population and chronic illness. Very controversial in general practice, but as somebody with a big interest in cardiovascular disease, I don't understand how we would do it without the QOF. So I think the QOF is very important. Enhanced services are more locally determined now. And then, of course, on top of that, are the stuff I do, which is all private medicine. So if you have your holiday vaccinations done at your GP practice, not part of the NHS contract at all. If I fill an insurance form for you, that's not part of the NHS contract. This is all private work on top. So you need to remember what a state we're in. However, the real state we're in is there's not many of us. We're a dying breed. So I could have picked any paper, but I picked the one I'm financially supporting, saying that we're now working beyond our safety levels. And I think we all heard this report, and it was quite interesting to look at the comments page on everybody's favourite medical journal, the Daily Mail, which said, yes, and I know who the incompetent doctors are, and there was loads of names in there. Shame we don't have the libel laws of America, really. But we are working beyond safe levels, and that's because we've got a decreasing workforce. And what the consequence of that is that we're getting less satisfaction for our patients. And that is a real big problem, because the NHS and the Department of Health is wanting to actually think about financing GPs through the opinion and the satisfaction of their patients. So if that's dropping, GPs need to pay attention to this. I mean, God forbid, we might be even less trusted than politicians one day. You know, if this happens, this is going to have a major consequence on general practice. But the one thing we can see already is that practices are closing. Now, of course, 18,000 practices set to close doesn't mean those patients won't have anywhere to go. They'll just be registered with other practices. So we'll look after the patients. We're just going to have to actually look after them with a smaller number of practices. So what does Albert say? Well, of course, there's always opportunity. And I'm one of those guys who quite likes chaos. Because while everybody else is in chaos, you tend to walk through the cracks. And so what we've been doing is forming a new group in Bradford. So when I joined general practice, I became a partner of a small practice in Shipley, had 7,500 patients. What we've been doing is we've been stripping that practice back from all the various work that it would do, because we did lots and lots of different things, back to the core contract. And the reason that we've been doing that is so that we can make my practice look exactly like the practice next door, and look like to the practice next door to that, so we can start amalgamating our partnerships. And at the end of this week, we're signing off our merger with another 2 practices, which will bring the affinity group up to 8 practices covering 65,000 patients across Bradford. That gives us a lot of opportunity to start doing things systematically, because we have the patient base to do it. Why have we done it? Mainly because people said we couldn't, and that's always a bad thing to say to me, but because it's going to make us more stable. So we can have groups of practices. We have practices in the north of the city, in the south of the city predominantly. We get them to work as groups. So when my IT system went down at the practice at the Willows on Monday, we just upped camp and moved to the practice next door, because guess what? We ran that one as well. So it allows us the flexibility in a moment of crisis. It also means that we can start sharing staff. We can have peripatetic staff moving from one practice to the other practice. So we can have specialists. Whereas a single practice, we can't do that. And the more you recruit specialists, the more you can hand work on. Of course, we have to have a good governing board that oversees everything. And then we have a strategic board, which is essentially the partners who do things. And I'm the clinical director of that. So what are we trying to do? We're trying to get seamless care. We're interacting with our local schools, because we now are the main provider for nearly all the children in that schools, because we have the surrounding practices. So it allows us to be a little bit more seamless. It allows us to play with new tools, and I'm going to go through a few of those. We're getting to know our local voluntary services better, and rather than depending on the CCG to commission what we want, we're commissioning it directly to the practice. And because they feel that's more stable, they are accommodating not necessarily what the CCG feels is needed, but what we as a provider think is needed in our population. What we're trying to then do is actually get the Care Trust to give us back our district nurses, so we can have the community nurses and make sure that's seamless. So we're trying to do this through a larger group of practices. However, we run 8 contracts in 8 lists. However, we know that that's not necessarily the direction of travel of the government. So we have to be careful about what we're going to get around list-based care. Most patients like their general practice. Within our group, we have tried to maintain the fact that if you are a Willows patient, you know that you're going to be seen at the Willows, and you'll be seen by one of the doctors of the Willows. We've not gone for homogenisation, although it does look like some people elsewhere would like that. So that's a little bit about the climate in general practice. Let's look at a few of our issues. And one of our biggest issues, and I'm sure people in this room could testify to, is access to general practice. So how can we change that? Because we're still working in this logic that if you need something doing, you need to see the GP, and you have to go through reception to get that. So it's faster online. So we're now looking at a method of using our website much, much more to direct people appropriately and to actually assist in management. So we're using a company called Footfall, and we're now actually working with Footfall to give a back door to the system. That means our nursing homes and our local pharmacies don't have to sit in our reception at all. They will have a special password protected pathway into our system so they can get to us quicker, because we want to do as much as we can online, because the more it's automated, the less staff are needed to run things. So if you look at what Footfall gives us, it gives us options. So if you go to reception, and actually all you need is a sick note extension. As you go through the reception button, it says, do you need a sick note? In one of its multiple options. Is this an extension? And rather than needing an appointment, a message goes to the doctor to do that sick note and either does it or will contact you directly. For treatments, it talks about minor ailments and says, well, if you've got earache and you've only had it for 24 hours, you don't need to see a doctor. And it gives you, then moves you on to NHS Choices that gives you advice about how to manage your symptoms. In the consulting room, you may have been given a message by somebody like myself that what I need to know is what your blood pressure's like in a few weeks' time. Can you check it on your home monitor and let me know? So you can go into the consulting room and send me a message to let me know how you're caring for your own health. Means that you do it at your convenience when you can access the website, and I can pick up the message at my convenience and reply. The travel room. I have no idea where you need malarial prophylaxis, because I'll tell you, you don't need it in Bradford as a rule. So I don't want to actually see that. I don't want people to waste their time to come to ask me of a question that I can't answer. So we can put that into one place. The area that I'm most interested in how we're going to use is the health review. How can we get people to assess particularly their cardiovascular health? And I'll dwell on that a little bit later, but how can we get them to review their own cardiovascular health and start to realise how they're doing? We had a comment again in the earlier session that everything's disjointed. You know, should you eat this food? Should your blood pressure do that? Should I exercise this much? How much veg should I eat? And everything's coming across in a very broken way. How can we bring that together into a single message, or even an option? So I know that I can't do that bit, so I need to do more of option B. And we need to start using our tools better to improve access. Because if you can manage yourself, that's one less person who needs that appointment, and I will use it for somebody else. The one thing I haven't got is any spare appointments. So we need patients to manage themselves better to do that. But if you're online, how far can we really take that? Again, Albert tells us we have to think outside the box occasionally. So we came up with Rapid P. Rapid P is an idea that there are certain conditions that NICE have decided need certain forms of investigation. Now, those of you who are familiar with NICE will know there are thousands of guidelines from NICE. And I can't know them all. So why don't we start picking up the ones which can be cannibalised and refined? So what Rapid P does is it sends you to a website about indigestion, and this is the first of what will be a whole series of conditions. We're developing the next one now. And it's about indigestion. Common symptom. People come to see us with it. But it actually is not very well managed. NICE have very, very clearly defined who should be treated with Gaviscon, who needs to have an endoscopy, who needs an endoscopy now. And NICE have defined all this. However, when you come to see the GP, what we can see from me and my partners, and we're a typical group of general practitioners, is some of us seem to follow NICE guidance. Some of us seem to follow NICE guidance even though we didn't even know it existed. Some of us are well off the mark and would scope everybody. So Rapid P asks you the questions that NICE wants to know. And because Rapid P hasn't got a brain, It's just got an algorithm sat behind it, and that algorithm was written by the clever people at NICE. It does what NICE wants you to do. So we now have a system where you go to the website and you say, well, I've got indigestion, I will go and do Rapid P. And Rapid P will take you through that series of questions, and it essentially is triaging you without seeing the doctor at all. And we've piloted this now. So we started off, obviously, with a paper-based version, just to see how things worked. Working with Kavita Oberoi at Oberoi Consulting, we then developed that into essentially a web-based tool that we could run through iPads. And we piloted it again. So every time it was people I had seen, and I'd made a recommendation, I'd then get them to fill in the questionnaire to see if NICE and me agreed. I'm glad to say generally with me it did. But having said that, I'd just written the algorithm. But it was interesting to see how people varied. Once we'd got it working, we used our MJOG system, a system where we can send mass texts out to our population. And we sent out a fair few texts. So we sent out over 20,000 texts, which essentially said, have you had these kind of symptoms? If so, go to this web link. And they went to the web link. And it was interesting to see the split. Again, the session I joined earlier was talking about age. And what we can see is actually this is a way to access older people. It did work to get hold of people. Now, most of the people had minimal symptoms and wouldn't actually require intervention, so they're in the green group. However, easily a third of the pie is showing that they've eaten too many pies and they're getting true indigestion, and indigestion with worrying symptoms. A small group needed to be probably seen by the GP, but the vast majority fell into the protocol to require endoscopy. Then we hit a barrier, and I think this is an interesting barrier, which is if you've been online, even though I've sanctioned it as your GP, and the machine says you need a test, are you going to accept that? We're just a little bit too early in this curve? Because what we found was actually there was a group of people who didn't want the test. And I think it would be interesting to look at that group to understand better why they chose, even though they filled in the questionnaire, not to proceed as advised. So if we look at the first 30 tests, what do we find? Quite a lot of pathology, actually, including a tumour. So remember, this is somebody who wasn't in contact with general practice, who through direct approach, we've actually diagnosed their GIST tumour, and we've diagnosed it actually at an incredibly early stage. So they're almost certainly going to be cured. So we need to consider how we can use this in other ways. The next one that we're going to go for is hematuria. So this worked quite well. The response rate, I think, was poorer than we anticipated. But to say that, we just said, let's have a go. And I think if we were to do this again with a little bit of support of local media, have a chat to Harry Gratian on the Look North sofa, I think we may find that we got a bigger response. But so far, it's interesting to see where it's heading. And it's a different way to come into contact with people. Because if all those people fill in their Rapid P, that loosens up appointments. And hopefully, I'm not working beyond my safety levels. Bugbear of mine, NHS Health Checks. Important stuff, though. But when health checks came up, the way we were going to do it was just to look at it in the way we always have. So the general practice body was not particularly pleased with health checks. And one of the biggest issues we had was what were we going to do with these thousands of patients who are going to show up with all this disease when we can't actually cope with all the disease we've already got. So we have to again look in a different way. Now just quickly, overview of cardiovascular disease. Cardiovascular disease is an array of illnesses. And We are all at risk of cardiovascular disease. Unfortunately, most people in this room will shuffle off this mortal coil as a consequence of vascular disease. So we have to think about how we're treating it. I mean, first and foremost is education. And again, I'll refer back to the questioner in the previous session saying that education is not going well, because I think it's confused. When people are at higher risk, then you start to get interesting to the GP. So if we were to do a cardiovascular risk assessment and we looked at your CVD risk and it's over 10% as defined by NICE, we should think about giving you a statin. Oh, we've medicalised normality. Everybody's crying. And the way that the media deal with this is they turn it into a cholesterol discussion. You know that statins have nothing to do with cholesterol? If you're at risk and you take a statin, your risk will fall. I'm at risk, I'm on a statin. When I went to see my GP to ask for it, Andy Wilson, nice guy at the local practice, and I went in and said, "Hey, Andy, I'd like to go on a statin." He goes, "We haven't done your bloods, Matt, we don't know what your cholesterol is." I went, "Don't care." And sat there with a grin on my face, baiting him out. So he asked about the kids and did me a prescription, because it doesn't matter. But that's not the message we've given the population, and we need to try and get hold of that. Other people have really modifiable risk factors, blood pressure issues, diabetes, and then the line progresses. What is true, though, is that all these illnesses that you can see listed at the bottom are not different illnesses. They are all manifestations of the same problem. Yet we're not educating even the doctors to understand that properly. And because they're all manifestations of the same problem, they all need very, very similar treatments. And the one thing you'll see running across all of that is blood pressure control. Because blood pressure control is really important. If we want to reduce stroke in this country, we need to address blood pressure and a heart rhythm problem, which I'll get to in a moment. But how are we going to do that? Firstly, we have to get rid of this opinion, which is, are the health checks a waste of time? Because if you read in the GP literature, they'll tell you that they are. But I will tell you that blood pressure is asymptomatic. Like that person who didn't think to come with their indigestion with their gastric cancer, because it's just indigestion. Blood pressure is even the step beyond that. It doesn't cause anything at all. You don't know you have it until you have your stroke or your heart attack. And in recent significant event audits in our practice, we do a significant event on anybody with a heart attack under the age of 55 or a stroke under 55. They're reviewed by one of the cardiac GPwSIs across the whole group. And the one factor that's always there, you are hypertensive at registration, and nobody picked up on it. So we can have this conversation as GPs, but I would argue that the work is important, and we just need to find a way of doing it. When we look at John Robson's report about the health check, what we find is that pickup is very poor. The actual identification of disease in that cohort isn't bad, but people aren't attending. And again, I'll go back to that health literacy and say we're not articulating this discussion with our patients properly. But when you get the blood pressure, what we need to do is make that side of things easy. And again, there's a very thick, nice guideline on hypertension, guideline 127. And it's thick, and I've read it. I suspect I'm one of few GPs in the country that's read it, but I have actually read it. And it decounts down to this, which is, if somebody's got a higher blood pressure that's bringing cardiovascular risk to them, how do we assess the level of that risk? And as you go down on an ambulatory blood pressure, it's either low risk, highlighted at green, orange risk, where you're into the borderline. You should do something about your lifestyle. You should try and minimise other risks. Otherwise, your blood pressure risk is going to become significant. Or it's significant and I need to treat with medication. How do I treat it? Now, this was the next 200 pages of the guideline, and I've decanted it down to a page again. Because actually, that's what my GPs want. And not only that, why do you need a GP to do this? What about a pharmacist? What about a cardiovascular practitioner? Let's train our HCAs up so they're very good at blood pressure. 1 in 5, at least, of the adult population have hypertension. And it's complicated if you run into lots of different drugs. But if you just stick to the same medications and do it in a systemised way, and you have a very clear target, and you have a very clear idea of who you send on to, at the bottom it says, if you're having trouble, send it back to the GP specialists and the cardiovascular nurses. Why can't we just systematise it? Then that fear of all that work coming in through general practice from the health checks is actually dispersed into my more diverse team with people doing what they do the best. There is a little problem in this, which is that I need to know what the blood pressure is. So you have to get a blood pressure done. So how do we do that? Let's go to technology again. So at the presentation where me and Hannah met, there was a guy wearing an ECG belt that could record his ECG. And I thought that was really all right. And he showed me, incidentally, his SFIG that talks to my computer through Android and iOS. So I can hand these out to patients, and they do their blood pressure on my recommendations, but they don't have to come to practice to get that done. I just get the data. And actually, I get loads of data, and it's really useful, because when I see that the blood pressure has plateaued on that particular intervention, I know it's time to make an adjustment. And of course, if it plateaus at an acceptable level, I can let the patient know that. Do I bring them in? Do I phone them up at an inconvenient time? No, I send them a text and let them know. And of course, some of my patients don't live local to the practice. So if I need to change medication, what do? I electronically send the prescription to where they are. So all of a sudden, this massive workload of the NHS Health Check is being broken down through simple protocols and simple technologies, so we can manage it in a better way. By the way, statins are even easier, which is you should just tell virtually everybody to have a statin. If they choose not to have it, but they've made an informed choice, well, they've made an informed choice and they choose not to have it. Hopefully, they're going to maximise another way of reducing risk. Exercise more, reduce their body weight, watch their sugar intake. How do I proceed in that? Can I have that whole conversation in 600 seconds? No. So I hyperlink them on a text message to the British Heart Foundation or to Heart UK so they can gain more information and hopefully take their tablets. It's not about medicalisation of normality. It's trying to keep you normal for as long as possible. People with heart failure don't seem to run up the hill very well. Another common condition, and I've talked about this before here, is palpitations. Palpitations are a symptom that really worry people. And I see a lot of them in my cardiology clinic. And unfortunately, some of that is due their anxieties due to their GPs who have forwarded them onto my cardiology clinic. Because if you're going to the cardiology clinic, you must have something really wrong with you. Well, palpitations are actually a sensation of your heart beating within your chest. So if any of you really had to sprint for the bus and you feel your heart pounding, that's palpitations. It's just a term. It doesn't mean a disease. What does the patient mean? We need to know. We need to know how they're experiencing their palpitation. What do they want to know? I'll tell you what they want to know. Is it going to kill them? Because it can feel really unpleasant. Some of them actually want to know what it is. But in my experience, actually, that's not the majority. The majority want to know that it's not going to do them any harm. And if it's actually really inconvenient and it's disturbing their quality of life, can something be done about it? They don't particularly seem to want a label, although I can give them one. What does the patient mean, though, is the really important point. What are they experiencing? And I find that it's actually quite useful to get them to go and write it down for me, to keep a diary of their symptoms, because I'm interested in that. And it's interesting how you can start seeing the correlation between food, between anxiety, between stressful events. So keep asking the patient what they want. Not going to do many published papers, but Webber is important in this context because Webber looked at the outcomes of all investigation for a cohort of people with palpitations. And his results were very interesting in the fact that actually less than half had a cardiac cause. So if you were a GP, you could almost argue that you should start from the point of anxiety management before you even get into the dysrhythmia. And as we go down the cardiac dysrhythmias, we find that most of them aren't dangerous. So we're not actually giving the right message to our patients. What happens with the patient? I tried to draw this out. I was asked to draw out a flowchart of what happens to patients. And so, you know, they either present to me or A&E. If they go to A&E, they may get sent back to me, or they may go into the hospital and see the cardiologist. And you can see that it's a bit of a tangled web. So, when they go to the hospital, when they come to see me, do we take the history properly? Don't know. The symptoms, do we take them properly? Don't know. Family history, the single most important thing about your cardiovascular health. What did your parents do? If they lived to 100 without any cardiovascular disease, it's unlikely that you are. You won't follow them along that line. If they died at the age of 50 with a massive heart attack, I'm afraid 50% of that's already in you, so we better start thinking about it. So family history is vital. Now, I showed you the complex web, and I'll say this is actually what really happens. If people get panicked by their unpleasant symptoms, or something else happens close to them. It's in the news about the 50-year-old guy dying on the way home on the bus, or the young lad running onto the football pitch and dropping dead, and it panics them. So they start entering the system all over the place. And it just doesn't seem to work very well. What do I want to know? Is it going to land me in trouble if I miss this? Is it going to kill the patient? Because that usually lands me in trouble. So what I want to know is, what's the risk? Because actually I spend most of my time in general practice just assessing risk. And I can do that. And in fact, it's very easy to assess risk in palpitation patients. So let's take you through the patient journey with palpitations. You know, you go along to see a GP, I refer you to the hospital, consultant gets a letter and decides that he'll see you. Then you get a 24-hour tape. We'll talk about them, they're brilliant. Then we have that shows nothing. So we get a 7-day tape. That shows nothing. Because guess what? That week you didn't have your palpitation. And then we consider an ILR. ILRs are implantable ECG machines. But the hospitals don't like them very much because actually it occupies their lab space and they don't get paid very much. And then they disappear from the system. Partly because the patient stops going because they're not getting any satisfaction, and partly because hospital systems tend to lose people. So we have to find a different way of doing this. Briefly about investigations. This guy's important, Einthoven, because he invented the ECG machine. We need to think about how we're going to use that, because that's a crucial investigation. So this is a Polish lady who had palpitations for many years before she saw me. And when she presented, very good English, but she still said, like, when I was a kid, they thought I was mad. Went to see the guys in Leeds, and they thought I was mad. And now I'm here with you. And she had that slight glint in her eye where I think she was challenging me to say she was mad. It took us about 7 days to actually get a diagnosis. Did we use an ECG machine like this? Not really. Did we use one like that? Now this is why so many people, when they have 24-hour tapes, you'll find the cardiologists call them 24-hour tape. It used to all be magnetic tape. Of course, it's all solid state nowadays. £75 backpack with the machine must have given you palpitations, though, I have to say. So let's look at just a little bit of work around ambulatory blood pressure, ambulatory recording. What we find is that if you do it in people who, in this situation, they're falling over, and you just put tapes on a load of people who fall over and a load of people who don't, and match them for age and weight and sex. What do you find? The tape just gives you the same information twice. So there's no difference in what the tape is finding, but we're still using it. Why are we still using it? Because it's cheap, and it's the way we've always done it, and it's never given us the results we require. Albert knew about this. So its diagnostic rate is low, about 4%. If I went to my CCG and said, I've got this technology, about 4%, they'd laugh me out the room. However, we're using it all the time. Best paper I could find is 15%. Still pretty poor, but it's cheap, and so we use it. So what did I do? I used the smartphone technology and sent her away with a cardio device, or a live core as it was called back then, and told her just to record her symptoms for me and send them to me. And so she did. And over the weekend, I could never have got a tape on her that fast anyway. She had her symptoms, and she sent me her SVT. Now I can tell, I know this looks like a load of squiggly lines to people who don't know ECGs, but I can tell that's what we call an MVART, a nodal re-entry tachycardia, and I know that that can be easily treated by my friends in the electrophysiology labs by ablation. So this lady's had 14 years of a condition that if we'd found it, could have been cured along that path. So we've been using these for a while now. I'd asked for some more data from my team, and they sent it on the train on the way in. So it was a bit too short for me to analyse it. But a few months ago, we had 130. We've now got 200 recordings, because we're just doing more and more and more of this. And we're using it for people with palpitations. We're also using it for those people who've got a very high suspicion that they may have a condition called atrial fibrillation associated with stroke, and occasionally in blackout. And what we find is we're finding dysrhythmia. And very interestingly, we're finding dysrhythmia in the same proportion as Weber did. So we seem to be finding the dysrhythmia that Weber says is out there. And when we actually look at the subgroups, the SVTs, the AF and so on, again, they're matching what Weber found. So we seem to be finding actually most of it. Actually, Weber never found any AV dissociation, and that's incredibly rare, but we spotted it in this device. And not only that, we've now realised that the people who send us the traces, and they send us more than 5, and they're normal, don't send an abnormal trace. So at the minute, we're leaving the device with them for 2 months. But if they send us 5 traces, which are all sinus rhythm, everything they're going to send us is sinus rhythm. I had another chat where we give the device for 2 months, and it was on Bernie, my colleague's list, to call him the following week because we needed it back. He'd gone 7 weeks, hadn't heard from him, he could have been dead. Nothing at all. And then he sent us 2 traces with fast AF. There is no way I could have caught that through any other technology, except from the guy wearing a device every 7 days and being permanently tied up with it. You can't shower when you've got these 7-day devices on, by the way. You've got to give yourself bed baths. So let's remember what we're looking for. We're looking for a symptom of palpitation. We are not looking for dysrhythmia, because actually, in the majority of people with palpitation, that's not going to be their problem. Their problem is going to be elsewhere. So just another patient, just to really highlight this, a 35-year-old lady, when she presented at the age of 30 with her palpitation, she went to see my colleagues in the cardiology department in Bradford, and they couldn't tell her what it was. I got the very distinct impression from the letter from her GP that she was very unhappy with the fact that this hadn't been clarified. So I saw her, and I got the very distinct impression that she was not very happy that this hadn't been clarified. And so we gave her an alive call and sent her off. And she sent us her symptoms, and we got lots of traces. And they were all normal. So I gave her a longer appointment, because I knew this was going to be a difficult appointment, because we hadn't identified her palpitation. And when I said to her, I can tell you absolutely that every time you're getting your symptoms, there's nothing wrong with your heart. The whole consultation changed direction. And she revealed the fact she had been traumatised in her youth by a family friend. And I managed to deal with that as a general practitioner because, unfortunately, that is part of my day job. And I made sure she was referred to the appropriate self-health groups. To be fair, I'm glad that she didn't see a cardiologist because I would suspect that that would have completely wrong-footed a cardiologist. But I diagnosed her palpitations. So we need to move away from this. And I have at last, after 2 years, been given the authority to pilot across the practices of Bradford an alternative pathway. The pathway is revealed on the right of the slide. As you can see, it's a little bit less congested. Because what we're going to do is we're going to educate our GPs, a key GP in each practice, to be able to take the history properly. Train their nurses to fit the device, so to sort out the device on the phone. So that actually the patient doesn't leave the confines of their own medical practice. Try and take down the medicalisation of their palpitation. And then we'll do the trace interpretation because that's where you need me in the system. Because I'm the person who can read the ECGs. And we'll send back the management plan to the GP. Some of the time that's going to be you need to actually send this patient over to Leeds for an ablation. Sometimes it's going to be because they've got different dysrhythmias. So we need to outline to the GPs what the pathway will look like for different dysrhythmias, but the major one is atrial fibrillation. And I said we'd get back to this because there's two major causes of stroke. One is hypertension, and the other one is atrial fibrillation that we can treat with anticoagulants. So let's make the guideline as simple as possible. So I was on the GDG that wrote the NICE guidance. So I actually read the 580 pages of the NICE guidance, which may be why I've been able to decant down the important facts into how to find it and anticoagulate it and how to treat it if it's symptomatic into two flow charts. So when I say to the GPs, this is what I've found, or even if I say to the patient, this is what I've found, I can actually show them how we're going to manage it, because it isn't that complicated. If you strip out the possibility you have to have a pathway true for every single person in the population, if you're happy to hit about 85%, you can draw out nice pathways. The problem with the live call and the phone, of course, is you have to pick it up to make it record. When you black out, unfortunately you've blacked out, so you can't do that. So is there a way that we can get into modern technology for that? Because actually, putting on a 24-hour tape, if you don't black out that day, I've still not seen anything. But I can't use a patient-activated device because what's happened has happened, and it's passed before you can get to the device. So let's go to technology again. And there's always something else that you can look at. And so what we're going to play with is Nubo. Nubo is an ECG device held in a vest. So no wires. And it just has electrodes which are built into the vest and stick to the skin. You can actually put this in the washing machine. So you can clean this. You don't have to be stinky, because you can actually use this very easily. And in fact, today, Bernie, who has to try all my devices, it's really good. Don't only have a good assistant, have a really good trial person who you can just ask to do these kind of things. And Bernie's wearing it today, and will tell me what she thinks. What we need on the other side of it is an easy-to-follow pathway. Because if we record it and you don't show any sign of dysrhythmia, then invariably the problem is all going to be about salt and fluid. And one of the big problems we have in blackout is we're all told not to eat any salt. But unfortunately that's the wrong advice for about 15% of the population. And if they reduce their salt intake, they're going to pass out. So the next thing we've done after we've proved that it isn't dysrhythmia through Nubo is we can then give very directed advice about salt and fluid. Because we're going to go 100% against the national guidance on salt. I'm going to prescribe you salt tablets. So it's important that we get that right. Getting towards the end, this was a piece by a professor of primary care, and sorry for the text being so small, I was hoping it was going to project better than that. What I was wanting to highlight is as we go through his report about primary care, what we find is that he thinks that we should make more GPs. My wife's a very keen knitter, so I've got her onto that straight away and see if she can knit me up a few. Because it takes about 7 years after qualification to become a GP. And if you talk to my patients, they'll tell you it takes about another 20 years after that to become a good GP. So that's a nice idea. The other thing that he thinks we should do is to stop doing all this unnecessary work, like cardiovascular protection and such like, which again doesn't seem particularly helpful. Pay us more. Actually, I don't know many GPs at the minute who are... To pay a GP is usually a good way to persuade us to do anything. But actually, it's not a good way to persuade us at the minute because we're just thrashed. And you could say, we'll give you more money to work on a Saturday. And I think you'll find we'll say no. What they've actually done is said just work on a Saturday and they haven't given us any more money. But it's not going to work very well. And it says that the NHS should look at its system so that people can go directly into the hospital, so directly to a consultant. Why come to see the GP? For me, that's just moving the issue one tier up the system. If we've not educated patients to truly understand the fact that their palpitations have got a 1 in 2 chance of being nothing, they're all going to turn up at the cardiologist's door. So I'd argue that actually the solution is that we need to come up with a different solution. And that solution is going to be technology. And even as we get to the end of his piece, he just about says it might be a good idea to think about doing things in slightly different ways. So what does Albert have to say? Albert says we should always keep moving. And that's true. The one thing that my practice has never done, and my personal practice has never done, is stand still. We once tried it. We took about 3 weeks before we all went slightly mad. So you've got to keep moving, and you've got to engage with new technology because it's the only way that we're going to sort out primary care, whatever primary care is. And the only way to do that is every time you hit a problem is to ask, what is the solution to this particular problem? And to talk to other people, because sometimes the solution to your problem has been found by somebody else. Thank you very much. Any questions?
Thank you very much. Really interesting talk. I actually have a million questions, so right. I'll try to maybe ask kind of a two-parter question. When you're talking about receiving blood pressure readings regularly from patients, I mean, that's quite a shift. It's great to see you can do it remotely and stuff, but how do you manage that data on a regular basis? And what's required in the GP setting in terms of training and adjusting your workday and how that workload now looks? And also, are there potential ways of the GP not always being the first person to see that data and looking for patterns?
So, if I can answer that,
yeah.
I was conscious of time, so I kind of jumped through a few things. The blood pressure is done at the patient end, and it comes into a cloud, which is actually based in Holland. God knows what the Brexit's going to do to that, but it's currently based in Holland. And then I view that through a portal on my desktop, or my team view that through a portal, and I can set parameters per patient. So I can actually say, for this patient, I want these kind of targets, or put a bit of an error bar on that. This I really need to know about. And so once people are at target and are sending through blood pressures, and I ask them to do it less because they're at target, if they fall into the green category, they're fine. If they're in the amber category, we start watching them. If they're red, of course, we intervene. And how do we fit it in? It's carved out of, I do it because I'm a nutter. My cardiovascular nurses have it in part of their workday.
So you kind of set those parameters early on, and then
at the point where we have the first consultation.
Because I was thinking that's great. That's the way forward. It's just, you must have thousands of them potentially across the practices. So.
But the other thing that's really important here is that I'm modifying people's medications on a trend rather than on a point of care. So you come to see me once in 6 months and your blood pressure's high. I'm going to modify your treatment because I Should I delay? Should I do a few more readings? Actually, what most people do is say, it's high today, I'm going to treat you. What I can see with all the data that comes in is actually the slow flow upwards, saying that you're going to need a new therapy soon. Put in that new therapy and see it stabilise. And I know that you're at plateau again. And I shouldn't muck around anymore. In general practice, that's a whole new way of managing blood pressure because we couldn't do it before.
Really interesting. And so my other question was, as a GP, what kind of requirements do you look for with integrating digital technology and data in terms of the understanding, training, format of that data, validation? Because obviously there are more and more technologies available. How do you even start the process of what you would require to integrate it into a practice?
So the first thing I need to know is that you're compliant. So I've got to understand how you are managing data because it's coming in through your device. How is that being dealt with at your end? Unfortunately, we're getting technology coming from across the pond. And of course, we're not allowed to send any patient-sensitive information across the Atlantic without patient consent. So that gets it even more complicated. So the first thing I want to know, and probably the only thing I want to know from the NHS probably, is that you are data compliant. And therefore, I can use your device and your data with impunity. Interestingly enough, that's not often a question from the patients. Even after the big Facebook scandal we've just gone through, I can't say that's a big issue that patients present, but it's a big issue to me. After that, I want to see how you're being validated. So ECG tracers. A lot of ECG machines, of course, have internal algorithms to work out what's going on, and I want to know how that's been validated. I also want to have reassurance that if you have an internal protocol, that if that's modified, that I am informed. So I can tell you that there are devices that within ECG technologies where the algorithms have been modified and they've become less specific, but I spotted it, I wasn't informed about it. So I think that how a company may want to sell to the general public and how they need to sell to me as a clinician are slightly different. And the next thing I want to know, particularly in therapy apps, so if we think about things that might help you sleep or alleviate your stress or help you lose weight, I want to see a study. I want to see that it's actually worked. And as I mentioned in the session earlier, I can accept that I might have to work with a slightly different evidence base from what I'm used to in large pharmaceutical studies, mainly because small startups haven't got the finance to do these big studies. But I want to be able to see that evidence and I want to be able to read that myself. I don't care if Professor Cleverness at the Cleverness University thinks it's a good idea, because actually I don't know what Professor Cleverness, his interest actually is and how he's seen the data. I want to be able to do that myself. And other GPs may be quite happy to believe that man, but there are going to be clinicians out there who want to see that data for themselves. Does that answer the question?
As always, Matthew, an absolutely brilliant talk. There are a number of questions I would like to ask you, though. The first one was around about the unemployment rate amongst pharmacists.
Yeah.
How you're going to use this opportunity to perhaps bring them into your practices. Yeah. What role do you see them having, and what responsibility would those people take?
So, pharmacists are really useful because they're registered and they have an authorising body. So that makes them more useful to me than HCAs in some respect. How are we going to use them? So we've already got pharmacists employed directly to the practice who are just doing medicine assimilation, so making sure the discharge summary matches with what we've got. So they're already doing simple stuff like that. They're also already doing audit work for us. So as we become much more antibiotic conscious, they're doing all the audit work around antibiotic usage and such like. So that's very kind of drug orientated and very back room. What we're also now doing is, in people who just need a medication review, you can make an appointment to see the pharmacist. So you come in and you can just see the pharmacist directly. And for things such as a cardiovascular script, you've got stable vascular disease, you just need a blood pressure doing. You need to make sure that there's nothing odd gone onto the list that may interact. And you want to talk about side effects. So we're actually using them as you could use them in the community pharmacy, but you're using them there and then coming to see the GP because they can't review the prescription. So we've got prescribing pharmacists who are doing that kind of work. And we're starting to plug them into the protocol. So we've now got a couple of pharmacists who I've gone through didactic education with them. They've done a few clinics with my cardiovascular nurses who now, after the diagnosis of hypertension with an ambulatory blood pressure monitor, the first appointment they get is with a pharmacist. And they go through hypertension and they go through the medications and they start you on your medication. And actually, they may never come back to see the GP unless they develop another issue because the pharmacist can do all of that.
You mentioned medication. If you've got a diagnosis of hypertension, then you're not just going to be medicated normally on one drug, are you? So no. Are they also looking at the way in which drugs interact with each other and contraindications? Absolutely.
So, I mean, the protocol is written in a very, very strict way, and I'm sure you recognised immediately what I'm doing there is I'm building the polypill because I'm an advocate of that attitude to healthcare. So, yeah, that's exactly what they're doing there. But if, let's say, I put you on amlodipine, one of the dihydropyridines, and you get peripheral edema, most GPs will just stop that outright, where actually there are variations within that family where the edema is less significant, and the pharmacist won't just jump off that drug. They will make manipulation within the family. And for cardiovascular prevention, using dihydropyridines is important. So we don't want to have dismissed them. We want to make sure they've been given the best chance, and the pharmacist can do all that.
Are you also involving them in, for example, and the reason I'm interested is I'm going to be training some pharmacists soon from China, and I'd like to know how we are going to be dealing with pharmacists here in the future, particularly if there are too many of them. But my question was around, are you intending to use them as educators or to prescribe travel advice and medication for travel?
We already use them for that, but that's a bit of private business over there. So yeah, because I also part own a pharmacy in one of my various hats. We've been doing that in practice for a while. So travel advice is great, perfect for a pharmacist, particularly a prescribing pharmacist, and that's who we're recruiting. We want them all to be prescribing pharmacists, not just pharmacists. So, yeah, we can easily use them for that. What I'm not using them for, Duncan, is diagnostics. So the taking of the history and the making of the diagnosis remains with the nursing and doctors team. Once we've made a diagnosis and the management plan is set out, because most of this is NICE defined, then they can go and see the pharmacist who follows NICE. Because, of course, what we know is that doctors are very bad at following protocol. Other health clinicians are much better at following protocols, and we're hoping the pharmacists are going to show us that.
Okay.
Part of our issue is I facetiously made the comment that it takes 7 years to train a GP and then 20 years for them to become any good. We've got a lot of young, inexperienced pharmacists coming out of university because they've not had that time in the community pharmacy or the hospital pharmacy to develop their craft, if you would. And so it's going to be interesting to see how we use those.
Okay, thank you very much. My next question. Obviously, the national guidelines as to what is defined as hypertension have changed.
And yet, Duncan, you're ahead of the...
No, it will change.
Yeah.
Does that mean that you'll be reassessing all the hypertensive patients?
It's a good
I don't
job
know how many
they've
tens of thousands you've got.
Yeah, let me please hide. Hypertension, high blood pressure is a risk factor of cardiovascular disease. It's very rarely a disease in its own right. It's a risk factor. We have got a fantastic body that was designed to run away from lions on the Serengeti. Unfortunately, it wasn't designed to become old. And so we're in a situation where our blood pressure climbs with time. That elevated blood pressure is a CVD risk factor. So we're going to have a cohort of patients who we have previously said, we've taken your risk factor down, as low as the national guideline says, and you're fine, and they're going to come in after November, and we're going to say, numbers are exactly the same, you're no longer fine, we need to go further. Now, actually, I introduced the lower target a couple of years ago after Sprint. So for me, I think the impact's going to be less severe. But yes, it's going to be a lot of work. I think that the problem that we're going to have is the fact that we have a load of people who are currently classified as stage 1 hypertension without end organ damage who are on lifestyle alone. And I would put a pound to a penny that the definition of stage 1 hypertension comes down. Now, for us, all those people are coded because of the way we put ambulatory blood pressures onto the system. If it's free text, of course, you should never free text. But if you free text it in, all that information's lost. And I don't know how you go back to that cohort.
Oh, okay.
But we'll find it quite easily because of the way we do it. Because I always knew they'd change the parameters.
Yes. Do you actually trust your ambulatory live core? Having looked at the alternatives personally,
Yeah.
what I find is that the types of amplifiers used, actually the output needs to be filtered quite a lot to give a stable reading that doesn't go up and down across baseline, and actually is less likely, those ambulatory, less likely to give you indications of atrial fibrillation.
So first thing is I don't trust the algorithm. So all the ECGs are actually eyeballed. So the fact that the machine thinks they're normal doesn't matter. So they're all eyeballed. At that point, the person who's looking at the trace is doing a quality control. They don't think they can interpret what the ECG says. We put it down as unclassified. There's a lot of trace that the machine puts down as unclassified that you can actually read. And if you look at atrial fibrillation, where what you're looking for really is a very variable R to R variability, then actually you can sometimes see that in the noise anyway. So it's about the team's ability to read the trace, which is why we can't release this to the GPs and say, trust the algorithm, because the algorithm isn't good enough. And I know for a fact that they've downgraded their algorithm from all the evidence that's published. So it's not even as good as it said it was. And it wasn't particularly good when it was said it was quite good.
I have a feeling it's not just a live core, it's the other devices also suffering the same problem.
But I read them all. I don't trust any ECG machine. If you can show me the PQRS-T, I'm happy. If that happens to be on a bit of a hill, because I'm not looking at ST and T wave distortion, what I'm looking for is rhythm and P wave.
Absolutely, okay, all right.
I can allow the ECG to be distorted in other ways.
Okay, thank you very much.
It's not really a question, but I was wondering for how much GPs check with the patients if they do self-monitor some kind of health behavior, because I recently did a study in general population sample, and it turns out that out of 270 people, that 259, 44% people said they tracked health in some kind of way, and it could be because they want to have some kind of warning if there is a risk situation, or just in general want to improve their health. And they self-monitored in loads of different ways, but out of those 44%, there were only about 4 people out of the 259 that actually shared their results with professionals. And I think one of them was a GP. So there must be loads more information that might not be shared.
We're starting to see that. So that is definitely starting to come into the system. I spot people's Fitbits, and I will ask them about how many steps have you done. And I know it's not rigorous science, but it does give you an idea of activity and heart rates. So we are starting to see that. One of the things I'm starting to see in my cardiology clinic are the worried well, I have to say, particularly with Garmin. Don't get me going, but where on exercise, the way that Garmin works, it starts to pick up the diastolic notch and double the heart rate. So we're having people who are coming in saying, I'm exercising, and my heart's suddenly accelerating. It's like, was it twice as fast as it was? Yes, it was. That's because it's double counting. So we are starting to get that data through. I've actually had one chap who presented in my cardiology clinic with the ECG of his palpitation because he had done it himself off one of the belts. Somebody made a comment about social deprivation and the white middle class. He was white and middle class because this technology is quite expensive. But yeah, I'm very into that. I would argue that if you weigh yourself on a daily basis, you're doing health monitoring. So people are taking a lot of data, and I think part of the issue comes again to what the lady in the blue said in the session previously, is you weigh yourself. What does it mean? Yeah, because actually I'm less interested in weight and more interested in body shape. But we're not having that conversation with people, and it's harder to measure, so we tell everybody to weigh themselves.
Yeah, people that I'm a clinical psychologist, and I looked at the experience that people have when they self-monitor. So if they find it stressful or enjoyable or stuff like that. And diet and weight was one of the things that was more negatively experienced than other things of tracking like health or fitness. And I think that could be from the qualitative interviews we did, that when people are confronted with their weight, they associate it as a goal they didn't reach maybe. Or, well, when you track food, that might be much, a different way of seeing success in some way. What was very interesting is that people that track mental health or well-being, they don't share it with anybody. With all the other the finance, people share that. So that might be something as a GP also to look out for, that people might keep track, but they don't, with the stigma attached to it, might not share it so easily.
I think the mental health issue is another really interesting point as well, though, because local to us, you go to My Wellbeing College. So you don't actually need to see the GP anymore if you think you might be depressed or have an emotional issue. You can actually refer yourself directly in. And one of the solutions that you'll get from the counsellor on the phone is online counselling or online exercises. And in my experience, the younger cohort, the under 30s, seem to do much better with that than the older cohort. And I think it's because they've been brought up with computers and technology. They've communicated with their best buddies, or best besties, or whatever you call it. My daughter's telling me, and they communicate without actually seeing, and have these very strong relationships, essentially with their phone, that has somebody at the other end of it. And I think that they're interfacing with online counselling in a different way to those people who are much more used to direct social interaction. Yeah,
younger people tend to track more, and sharing data in general is helping in a positive way in how people experience self-tracking.
Yeah.
So anyway, but I'll shut up now.
Well, I think that on the cardiovascular situation, I think the idea that we start to develop that picking list and say, right, if you really don't feel you can get your body shape better, then we're going to have to work harder on your blood pressure, and you should take your statin, because there's an area that we can't reduce your risk in very well. So let's make sure we've absolutely maximised the areas that we can reduce your risk in. And I think that starting to have that conversation with people about the idea that in risk there is very rarely a single risk factor. There's a collection, and if you struggle with one, let's look at the rest of the collection and see which ones we can work with to minimise your risk. So I think we've become too fixed in our vision at the moment. And the cardiovascular agenda is massive, particularly, as Duncan says, when we suddenly drop the blood pressure targets, we're going to find a whole lot more hypertensives. What we actually mean is we're going to have reduced our threshold for when we should intervene in the risk of high blood pressure, but we're going to have a bigger cohort of patients.
Question. What's the initial response perspective of the patients being given these technologies, but also your colleagues and across the country, but also the up-and-coming GPs or medical practitioners?
I can't speak for the up-and-coming because I tend to keep out of GP education. I think I'm a bit too forthright for our precious trainees. As regards patients, I have a lot of patients who love it, and it's not just the young cohort. You talk to professionals, and people are working regularly to 17-hour days. And you can say, you've got blood pressure, but you don't have to stop work for me to manage your blood pressure well. They love that idea. The idea that we're giving you a technology that when you're worried about the symptoms you're suffering, you can tell me what it is. They do like that, and the rest of my team, I suppose, like attracts like in this respect. So the people who are around me in the affinity care tend to be very pro looking at technologies. But years ago, I don't know if anybody saw the film called That Sinking Feeling. It was about a group of young lads in Edinburgh who steal a load of sinks for various plot points. And they start talking about the fact that a pint of beer is about a fifth of a sink. And their whole terminology turns into this currency of sinks. The currency in general practice isn't money, it's appointments. And so we have to look at how we're spending them. And if I can manage a hypertensive for 5 years on 2 appointments where I give them cardio or whatever device, and they can then monitor themselves, and then I'm taking a teeny-weeny bit of time at other points to manage their disease. Actually, in that commodity, it's an incredibly good investment. It far outweighs the actual financial cost of the device. And I don't think many of my colleagues have started to move to the idea that their appointments are their currency. And anything that saves an appointment is money in the appointment bank. And that's it. They've got to change the way of seeing things.
Thank you. Yes.
Hi. Looking ahead, 10 or even maybe 20 years, the time to make a new GP. I'd be curious if you'd like to speculate about any new technologies or particularly digital technology trends or inventions that you think might have a huge impact on your work. Yeah. Robotics, drones, anything off the wall. Or
I think the technology, the implantable technologies, how we can actually invade the body to monitor, are going to get better. We all know about the devices for measuring blood glucose that we're using off the NHS, but in our type 1 diabetics at the minute, of course, they sit with a plug on the outside of the arm. I would suspect it's only a matter of time before they go below the skin. We're already looking at a technology, me and a friend are looking at technology that just looking at the waveform of the blood pressure between the wrist and the finger can tell us what your blood pressure's up to. So the idea you would even have to put a cuff on, you could put a glove on and I can monitor your blood pressure. I think the real things are going to change are the idea that we could start monitoring how you are weighing, how you are eating, how you are taking calorie into the body, how you're exercising, so that you're stimulated to exercise more. I mean, my watch is already telling me when I need to stand up. Very good for one of the trustees of the Thrombosis UK to try and reduce my VTE risk. But we're already getting that stimulation into the system. And I think the challenge to the researchers in the room is to show how technologies can modify behaviour. Because actually, if we look at a lot of illness that's going to kill us, it's behaviour that started the problem. If you are metabolically a cardiovascular person, that are going, essentially you glycosylate very quickly. You don't manage your lipids particularly well. Your arteries are going to become sticky. If I can detect that in a teenager and keep them slim, keep them active, then I'm not going to get to blood pressure drugs. I'm not going to get to the other things because you've been stimulated into a change of behaviour. So I think that's where the interest for me really lies. It's all in prevention, how to stop the disease before it's here.
We've still got a bit more time for any more questions. I know Matthew's going to be around this afternoon as well for a little bit.
Can I just ask you a question? And it's you obviously work with some interesting small companies that have technologies and you're developing your own. I'm just curious about what your thoughts are in working with small innovative companies or developers in your community versus what your hope might be for having larger companies who tend to be able to penetrate markets more, who can actually scale up these technologies and move them so they're more ubiquitous in the community. I'm just curious if you have any thoughts about that. Is it more fun tinkering around the edges with some of these technologies, or do you actually want to make a big change? And so that's a question.
Oh, that's a challenge. The way that I've worked, I mean, one of the and I say this quite a lot, one of the nice things about being me is the fact that because I've been around particularly the cardiovascular circuit and the metabolic circuit for quite a while, is that small companies come to me and say, look what we've done. And so I don't need to necessarily look particularly hard, because people actually come to my door and say, look at this. And the number of ECG machines I played with before Cardia happened to be the one that fit the solution, fit my problem, are numerous. So I tend to work with people who come to me. As regards the bigger issue, I do play with big companies as well, but they tend to be in pharma because they have penetration. So I think the biggest challenge to the NHS at the moment, looking ahead, is cardiovascular disease. We've got to stop people coming to harm from cardiovascular disease, because that's what's filling up our beds with all these people with claudicating legs, with dead hearts, with dead brains. You know, we've got to stop that disease before it starts killing our organs. And that means we have to really awaken the cardiovascular agenda. So I'm currently working with a couple of the players there who have got drugs coming into that arena to say, will you stop talking about your individual drug, work as a group and push the whole of the CVD agenda, because we need to start looking at it differently. Technology, I think, plays an important part in it, because we need to have change in behaviour. We need to have people in a better body shape. We need to have people not eating as much sugar, and unfortunately that's ended up at a tax solution, because tax works so well with smoking. And we've ended up with allowing our government to tax our food, which worries me a little bit. But yeah, we've got to get people to voluntarily change that behaviour. But going back to a comment earlier, you know, we've just flipped the whole of the lipid debate onto a sugar debate, and people aren't going to like us for that. So there's a lot of education out there. So the big agenda, I don't think, is going to be, you know, robotics helping people who've been paralysed walk. I prefer to stop you being paralysed. And I think that's where we have to really get. And technology in that respect is about lifestyle modification.
So thank you, Matthew. And on behalf of
thank you very much.
the organising committee, I'd like to give you this bunch of flowers.
Cheers.
Be careful because the thing is broken.
Yeah.
And just a card.
Thank you very much.
Thank you. And thank you. And I'm sure everybody's enjoyed your presentation.
Okay,
and I'm sure there'll be more discussion later. Lunch will be served in the atrium from approximately 1:45 onwards. Thank you.
Thank you very much.